Welcome everybody. Today we'll be talking about informed consent and record keeping. My name's Andrew Vitiello from the Anglo-European College of Chiropractic, and this is one of the lectures that you'll be taking for the Contemporary Chiropractic Unit. So when we look at informed consent and record keeping, what we're really looking at are two interconnecting concepts. And they occur every day in general practice. Now, these two elements are important because in recent reviews of public complaints made to various registration boards, the main issues that were constantly being discussed were these two key elements. The inability of the professional to keep adequate records, and also the inability of the professional to take proper informed consent. Now, in doing this, let's look at what these professional boards, not only from the UK but around the world, but what do they believe good record keeping should include. Now, before we go ahead, I'd like you to read these documents. There are a number of documents from not only the United Kingdom, but there are some documents from Canada, Australia, and so I'd like you to sort of understand these documents, and they're there to give you a sort of an international perspective of what the two issues are about. So all of these elements, or all of these documents that I'm asking you to read today, will be part of any assessments that you will be asked to take with regards to contemporary chiropractic. So please read them and familiarise yourselves with the documents. So why do we keep records? Well, records shouldn't just be the treatment that I provide on the day, whether or not the patient has paid, and what date they've come in. Good records should not just be seen as additional paperwork, and that you really don't need it, and what you're really there to do is help the patient. You see, records are a way in which you can objectively look at what was done to the patient at a later date. It promotes good safety. It promotes good standards. And the way it does this is that it often eliminates confusion. You know exactly what was done on a particular day. You should be able to know how the patient felt after treatment on any particular day. It allows you to streamline office procedures. If you have a good idea of what's being conducted on any one day, then you can plan your day out a lot better. It helps standardize treatment protocols. So if you can see that a patient with a particular type of treatments isn't doing well, you can go back and see whether or not different elements of that patient's treatment can be changed. It also promotes regular treatment management. So it does allow you the ability to set a date in the future where the clinician and the patient sit down to discuss how they've been going, to discuss whether or not treatment goals have been achieved, and whether or not it's appropriate to change the focus of treatment. Good records also allow for the mobility of the patient amongst not only the same practitioner or the same clinic, but different practitioners and different clinics. So having clear, legible and easy to follow files allows for that continuation of quality care that we all strive to give. It also helps protect your patient, and the idea of protecting your patient is one where it is clearly demonstrated what has been done. Any allegations of misappropriation, any allegations of misconduct can be easily refuted if your patient notes are clear with what happened on a particular day. And also medico-legally, it's the only objective account of the patient-doctor consultation. Anything other than that is up to debate with respect to either the patient's recollection, staff recollection, and the doctor's recollection of what had happened. So other elements of good records is that you should understand that you don't own the patient records, but rather you are just a custodian of them. You're a steward of these records. The information is and will always be owned by the patient. And as a result, in some jurisdiction, the patient also has the right to view the records and amend the records if the patient feels that the records are incorrect. They need to be clear and largely jargon-free. We understand that various professions have certain language that is specific to that profession. And so if that does become a problem, then a simple legend or a table explaining the jargon should be included in the files. It must be legible. That's very, very important. Patient safety can, in some professions, be severely impacted upon when it comes to legibility of instructions. Patient records must be kept in chronological order. This is very, very important. The records must allow a third party to arrive at a particular diagnosis. So not only yourself, but there must be enough evidence within the patient files that a certain diagnosis can be reached. So it's okay if you come at a different diagnosis, but the evidence supporting that must be contained within the files. It must allow for review. What that means is that the files must be contained or must be formulated in a way that milestones can be reached. And the idea here is that if a patient comes in and treatment is begun, then there should be somewhere in the notes that reflect that within 6 weeks or 4 weeks or even sometimes 1 week, there will be a review of the patient's progress. And this must be clearly demonstrated in the patient notes. Patient notes should allow for other professionals to assess your progress with the patient. And what we're talking about here is the use of outcome measures. So it's not good enough to have the patient or to write down in the patient files that the patient feels better. And then before you know it, you have patients that have been coming in for 6 months to a year or even more, and they're always feeling better. And yet there's no change in the type of treatment given, the frequency of treatment, and also the duration of treatments. So obviously that feeling good ceases to become any standard measure. So outcome measures are very, very important. Often our files will be scrutinised by other healthcare practitioners, particularly if a patient decides to go from a chiropractor to an osteopath, or to a physical therapist, or to a massage therapist, or to a physiotherapist. We need to make sure that our notes are clearly understandable by any relevant healthcare professional. And lastly, patient files must be kept in a secure area of the clinic. They should not be easily accessible by anybody else apart from the practitioner and, on request, the patient. So this is a very, very important aspect of what constitutes good record keeping. But sometimes things go wrong. Sometimes, beyond our control, things occur. And we often ask ourselves, where did things go wrong? So before we start to get into this, I'd like you all to understand that most of you will act as professionals. And as a result, you'll deserve your title and your place as a respected healthcare professional. But unfortunately, some of you listening to this won't. And there are things that are always bound to go wrong in practice. Often it's just a matter of time. It's simple statistics. The more people you see, the greater the chance that something will go wrong. And when it does, the real questions that need to be answered is whether or not that unfortunate incident was avoidable. So, when we look at this, the first thing we need to do is don't panic. But understand that the main question that will need to be answered relates to whether or not the complaint or the issue in question could have been avoided. And really, your notes are the only true record that can be used in determining that. Courts of law tend to place a hierarchy of evidence. So, pieces of evidence that are considered highly valuable or highly trustworthy, and others that are less so. And first and foremost, your patient notes are considered the most accurate account of what had happened. The second is the patient's recollection of events. And third, your recollection of events. So, as you can imagine, recollection of events, often there are biases that creep in, that shape your recollection. It's not uncommon for a patient to remember exactly what you were wearing on the day of the unfortunate incident. And often the practitioner can remember very little apart from what was in the notes. So the rule of thumb is the less a third party needs to question you regarding your notes, then the better it is. The less that is up for discussion. And what you really need to ask yourself is, do your notes accurately reflect what had occurred? And if the answer is no, then in a court of law, what other facts are also not included? And it's these other facts, or the questions surrounding other facts, which causes doubt. And in defending yourself on a negligence case, whether it is founded or unfounded, it is all about removing this doubt as much as possible. And the best way to remove doubt is to have accurate, clear patient notes. So the medico-legal considerations are that when chiropractors have been scrutinised by registration boards such as the GCC or courts of law, civil courts of law, record keeping is consistently a point of concern. Often poor notes make the chiropractors almost indefensible in a court of law. So it's very, very important that you don't allow lax record-keeping habits to make you indefensible in court. Now, in doing that, what you need to understand is that you shouldn't just write down all the objective findings, the history, examination, but also how the patient felt. And as much as possible, include the patient's own words. This gives any third party a better idea of how the patient felt after proposed treatment. So let's talk about informed consent now. Now this is part of your overall record keeping, but informed consent in its simplest form is really just a green light to go ahead with your treatment. Now, in doing that, there are certain things that we need to be aware of, and that some people believe that verbal consent is just as good as written and signed informed consent. But often courts of law have found this to be very problematic, and because of the inability for two parties to agree on exactly what was being said is something that various jurisdictions, particularly the Canadian jurisdictions, find that it's often best to avoid. Risks in informed consent should be clearly outlined. And this area here I've underlined because the idea of risk is something that we'll talk about a little later on. But we should keep in mind that consent never nullifies the patient's right to seek further damages or to stop treatment for whatever reason they feel is necessary. As long as the patient believes, whether it's rightly or wrongly, that they would like to cease treatment or to seek legal counsel as a result of treatment, informed consent never removes their right. Okay? So it doesn't need to be a real danger, but as long as it is perceived by the patient, then they are within their rights to cease treatment. So let's talk about risk. Now, we all know about the risks relating to spinal manipulative therapy, and there's plenty in the literature to suggest what the risk of having a catastrophic event following a neck manipulation. And all professionals, whether they be chiropractors or non-chiropractors, manipulators, non-manipulators, all agree that these risks are rare. But medico-legally, the idea of risk is not the same as what a statistician or the average person would consider to be risk. The medico-legal concept of risk extends to something new, and it broadens it to something known as material risk. And material risk is fundamental to informed consent. And as a result, if you don't understand material risk, then you really can't give proper informed consent. So let's have a look at what the Canadian judicial system believes material risk is. Now, the Canadian Chiropractic Association stated that the legal doctrine of informed consent is part of the general law of patient consent. Consent to treatment is often implied rather than expressed. And what they're meaning there is that by a patient simply making the decision to come and see you and is in your waiting room and then treatment room, that can be considered as a form of consent. But where there is a risk of significant harm from the treatment proposed, then the risk must be disclosed, understood and accepted by the patient. So what they're saying here is consent doesn't stop at just the patient being in the practice. Consent should extend to the risks being understood by the patient. It is clear from the case law, particularly in the decisions of the Supreme Court of Canada in Hopp versus Lepp and Riebel versus Hughes, that the test of what amounts to a material risk is wide, and what needs to be disclosed is judged from the viewpoint of the reasonable patient and not the chiropractor or any other health professional. So what they're saying here is what you believe to be risk and what you believe to be acceptable and unacceptable level of risk is irrelevant. It's what the patient, and more importantly, a reasonable patient, would understand to be risk. So, what this means is that the concept of material risk is now widened to catastrophic events. So it goes beyond catastrophic events, but also to quite benign events, which are often reducible and are often reversible, but these now constitute the wider aspect of material risk. So what does this mean? It means that a patient, or rather the patient's specific situation, must be comprehended and must be included in the practitioner's evaluation of informed consent. Risks or material risks must be clearly outlined so that every patient will have specific material risks. And it's not just about letting them know about stroke or other catastrophic events. And what I'm talking about here is this. Let's give you an example of an opera singer. And this opera singer has been a wonderful patient of yours. And this opera singer finds that having a neck adjustment before her practice or before her singing actually improves her projection. And she understands that. And she comes in specifically for that reason. Now, on this particular day, this opera singer sees you because tomorrow she has a very important singing engagement. And in the audience will be various record label producers. And if she has a really good performance, she may get a record label deal which will change her life forever. And as a result, she wants to be and be able to sing at her absolute best. So she comes in and gets an adjustment. Now, here's material risk versus what the average person thinks risk should be. Material risk should extend into letting your patient know that there could be a chance that she may have a bit of her neck may be a little bit sore after treatment. And that may impact on her ability to actually do what she wants to do. Now that's an important aspect. Because if the patient understands that I may have some sort of reversible, minor neck discomfort, but nevertheless it may impact on my singing, then what the practitioner has done here is made this patient's specific situation fundamental to informed consent. And the patient has understood that and would like to continue on with treatment. Now that is proper informed consent. Additional to this, we need to provide real options to treatment and not just different variations of the same treatment. And what we're saying here is treatment should not just be manipulative in nature, rather manipulation in nature, but it should be that often just soft tissue work or myofascial treatment would be appropriate. Often a different therapist may be appropriate, being a physical therapist or a physiotherapist. Or sometimes, even in acute cases, manipulative therapies may not be appropriate. In some cases, pharmacological intervention may be the most appropriate first step. And in taking and in continuing with this informed consent, the patient must sign that they have understood. And it's very important that you are able to answer any and all questions before the patient signs. And one last thing we need to understand is that indemnity forms are never defensible. A patient can never, under any circumstances, sign away their common law rights, and that is the right to seek justice if some error has occurred, whether that error is intentional or unintentional. So, this is just a brief introduction on informed consent and record keeping. Thank you for listening, and there are some questions that will come up at the end. So please take your time, read the documents that we've asked you to read, and take your time and answer the questions. Thank you.